regardless, so it could be bacteria, virus, fungi, etc. When we say antiseptic or antiseptic techniques, we mean that we use specific substances to either reduce or kill microorganisms on living tissues. So on surface of the skin, for example, before doing procedures. Examples of antiseptic include alcohol, iodine, hydrogen peroxide. And usually, because they are applied on living tissue like the skin, they have a narrow toxicity index, so they don't tend to be harsh on skin. However, this is not the case for disinfectants. So disinfectants are more of chemicals used to clean surfaces like floors. For example, bleach or Dettol, they tend to be very harsh on our skin or living tissues. So we always tell moms and dads not to clean the skin with Dettol, specifically after wounds or injuries. When we say clean, there is no marks or stains. When we say clean, sterile means free of microorganisms. Okay. So bacteria is either gram-negative, gram-positive, or atypical bacteria. So gram-positive or gram-negative means that we did gram stain on the bacteria. We use crystal violet stain. Okay. The uptake of the crystal violet stain differs between gram-positives and gram-negative. Gram-positives, they do have a thick membrane, so they have high or heavy intake of the stain, makes them very hard to decolorize later on. That will leave dark purple to blue stain on the bacteria. So if you see dark blue or purple, this is gram-positive. In contrary, gram-negative, they do have a thin wall, so they don't heavily uptake the crystal violet stain. So when you decolorize, they become colorless, and then when you add the safranin, they will turn red or pink. So gram stain is very important because it's the first step, relative quick step to identify the presence of bacteria, okay? Because usually cultures need 2 to 3 days to come back. So gram stain can give you some hint about the identity of the bacteria before cultures come out and can guide your management, specifically in kids who are very sick and you need to either escalate or choose a broader spectrum antibiotic before cultures are out. Okay, so pharmacokinetics, so you have to be familiar with those terms. So pharmacokinetics, what our body does to the drug in terms of metabolism, distribution, excretion, etc. Pharmacodynamic is how the drug itself interacts with the microorganism or the bacteria. So if it's bacteriostatic, means it slows down the growth, but it doesn't kill the bacteria. Bactericidal, it should kill the bacteria. MIC means minimal inhibitory concentration, which means the lowest concentration or the lowest level of the drug that's required to reach a visible growth of the bacteria in vitro, okay? So you have to visibly observe for bacterial growth inhibition in vitro. Okay, so based on the mechanism of action, we categorize antibiotics into cell wall synthesis inhibitors, cell membrane synthesis inhibitor, and protein synthesis inhibitors. And there are different types of protein that can be inhibited. We will come across them. So most of the antibiotics that we use in practice are under the category of cell wall synthesis inhibitors, okay? Okay, cell wall synthesis inhibitors like beta-lactams, lactobactams, and bacitracin. Cell membrane synthesis inhibitors like lipopeptides like daptomycin. And there are multiple examples of protein synthesis inhibitors that we also will come across in a bit. Okay, so we'll start with the beta-lactams. So beta-lactams include penicillins, cephalosporins, carbapenems, and monobactam, okay? So we call them beta-lactam antibiotics because they have beta-lactam ring. In the beta-lactam ring, there are 3 carbons and 1 nitrogen. And the carbon in the beta-lactam ring has a double bond with the oxygen. We call it the amide bond. And this is what makes the beta-lactam drink sometimes difficult to predict. And this is one of the main mechanisms of beta-lactam antibiotics. Okay. So, cell wall synthesis inhibitors, they're in general bactericidal antibiotics. So beta-lactams side effects, common side effects of beta-lactams include hypersensitivity like anaphylactic reaction, non-specific antibiotic-related rash, bone marrow suppression, nephritis or kidney injury, and GI-related diarrhea or Clostridium difficile. ليش بصير Clostridium difficile-related diarrhea?
Microflora. بتأثر المايكروفلورا بالantibiotics.
So specifically when we use broad-spectrum antibiotics or beta-lactams for prolonged periods of time, this will lead to disruption of the microbiota of the gut, or the normal flora will lead to the spore-forming Clostridium overgrowth and then diarrhea or C. diff, what we call C. diff diarrhea. Okay? Beta-lactams, they do not cover atypical bacteria like Mycoplasma or Chlamydia because simply they don't have a cell wall and they don't have any activity against methicillin-resistant Staphylococcus aureus. Okay, penicillins. So they're divided into 4 generations. The first generation are the simple vanilla spectrum of penicillins. This includes the penicillin V orally, penicillin G IV, and benzathine penicillin as IM injection. They have relative good coverage against streptococci, syphilis, and most of the oral anaerobes. Okay. Now, moving to the more extended second generation penicillins, we call them the amino penicillins, and this includes amoxicillin and IV ampicillin. So we call them amino penicillin. So they do have gram-positive and gram-negative coverage. They do cover enterococci, but non-vancomycin resistance enterococci. They cover Listeria, they cover group B strep. Now, with regards to their coverage for UTI, so as I said, theoretically speaking, they do have gram-positive coverage for gram-positive microorganisms that can cause UTI, like, for example, enterococcus that is non-vancomycin resistance, like Enterococcus faecalis. However, when we come to the gram-negative microorganisms that cause UTI, like we call them like E. coli, Klebsiella, Proteus, theoretically, aminopenicillin, they do cover them, but we don't choose them as first choice, as I previously said, because of the emerging resistance of those microorganisms to simple or second generation aminopenicillins. They do have good concentration, amoxicillin and ampicillin. So even though they do have good concentration in urine, we can achieve concentration, but we don't depend on them as first choice due to the emerging bacterial resistance. Okay? And they don't have any pseudomonal coverage. Third generation penicillins, or what we call them anti-staph, penicillins like dicloxacillin and methicillin, nafcillin, and oxacillin. They are excellent for methicillin-sensitive Staphylococcus aureus. They don't have any coverage against MRSA or methicillin-resistant, and they don't cover staph epidermidis or cones, which colonizes our skin. Fourth generation penicillin like piperacillin, tipracillin, when we use them along beta-lactamase inhibitors, they do cover for more extended spectrum like Pseudomonas. Okay, so penicillin with beta-lactamase inhibitor. First example is simply co-amoxiclav. So can we see how high above co-amoxiclav is? So it's a 4th generation extended spectrum. So from now on, when you hear a kid who has fever, most likely a viral fever, and goes to a healthcare center or a pharmacy seeking amoxicillin, now you know how bad this is. So amoxicillin is not a simple antibiotic, okay? It's a broad spectrum antibiotic. So it's amoxicillin with clavulanic acid, as we call it, or augmentin. The other option of extended 4th generation penicillin is the IV ampicillin sulbactam. So they cover gram-positive, gram-negative, and anaerobes. So they do have a very excellent coverage for skin and soft tissue infections and some intra-abdominal infections as well. They don't have pseudomonal coverage. Okay. طبعا احنا الامثال عندنا زي الدروبس اللي دائما بحكي زي العلكه بنعطى على الطالع وعلى النازل. برا مثلا لما كنا ببريطانيا في بالاي سي يو patients, sick patients who have pneumonia, sepsis, on ventilator, on adrenaline, نعطيهم IV comoxiclam. So IV amoxiclam is a very broad spectrum antibiotic. So ما نتساهل بالprescription تاعه. The other option is piperacillin tazobactam or ticracillin clavulinate. They do have excellent anti-pseudomonal coverage. However, they don't cover methicillin resistance to Staphylococcus aureus, and they don't cover vancomycin resistance enterobacteria or enterococcus. Okay. Now, cephalosporin, there are 6 generations of cephalosporin. So the more you go up with number, like 2nd, 3rd, 4th, 5th, the broader spectrum and the more gram-negative coverage they become, and somehow less gram-positive coverage. First generation, many options you can prescribe either IV or oral. Oral like cephalexin, which is an excellent option to treat UTI. IV cefazolin, they do cover for gram-positive bacteria like MSSA, MSSA and strep. They do have some gram-negative coverage for Proteus and Klebsiella E. coli, making them again a good option for treating UTI. They're as well good to treat soft tissue cellulitis and as pre-op prophylaxis, in specific IV cefazolin given in a hospital setting. Second generation, cefirixime is a great option because it comes in 3 formulations, IV, PO, and IM. Makes it less restricting to patients when you prescribe cefirixime. So you can start as an inpatient and then discharge the patient home to continue with the antibiotic course. They have excellent coverage for gram-positive, gram-negative, and this is a very excellent option to treat respiratory infections. Other options on second generations, cefoxitin and cefotetan, which are given IV. They do cover as well غير عن الجرام نيجاتيف الجرام بوزيتيف اللي حكينا عنها بالسيفريكسين. They tend to cover anaerobes like bacteroides. So this makes them very good to cover for intra-abdominal infections. Third generation cephalosporin, as you know, we have options like ceftriaxone that can be only given IV or IM, cefotaxime, ceftazidime as anti-pseudomonal coverage, and cefdoxime. They do have coverage against gram-positive, gram-negative. So they're excellent to treat pneumonia, excellent to treat UTI, excellent to treat meningitis, and طبعا في شيء اسمه meningitic dose. So ceftriaxone for meningitis, the dose is different from ceftriaxone for pneumonia. Okay, you have to adjust because it's we call them interval dependent and dose dependent both. So the choice of the dose and the interval of the antibiotic administration plays a role when you pick them to treat specific infections. Fourth generation cephalosporin, which is cefepime, it's very important to know about this because it has excellent coverage against Pseudomonas. However, it has very weak gram-positive. As I said, as you go up, less gram-positive coverage is observed. Fifth generation cephalosporin like ceftaroline, which is FDA approved for kids above 2 months of age to treat skin and soft tissue infections. They also do cover for MRSA, which is significantly of a great benefit in a hospital setup, and they also cover gram-negative, like, as I said, Pseudomonas. Sixth generation cephalosporin like cefidricol, it's only FDA approved for those above 18 years of age. Specifically for patients with complicated UTI caused by E. coli, Klebsiella, Enterobacter, and Pseudomonas. Okay, carbapenems are called the big guns. We call them the big guns because they have the broadest spectrum of almost all antibiotics. Okay, all of them they do have anti-pseudomonal coverage except ertapenem. So if you are, for example, covering ESBL positive UTI. So this is E. coli, okay? You need to start a patient on carbapenem. you have to think, how should I lower the spectrum of antibiotic I'm using? So instead of starting the patient on imipenem or meropenem that do have unneeded anti-pseudomonal coverage, I only start the patient on ertapenem because I don't need pseudomonal coverage for a patient who has E. coli UTI. Okay, so they have gram-positive coverage, gram-negative coverage, and anti-pseudomonal coverage except ertapenem. They are excellent choices for extended spectrum beta-lactamase producing bacteria and as well anaerobes. They have fairly good CNS penetration. They don't have MRSA coverage. They don't have coverage against vancomycin resistance bacteria or Staphylococcus. Okay, as I said, ESBL is expected extended spectrum beta-lactamase producing bacteria. So Enterobacteriaceae family, like E. coli, Klebsiella, Proteus, sometimes they get smart, specifically after recurrent and prolonged antibiotic exposure. تمام بيعملوا genetic coding and decoding فبصيروا they can produce beta-lactamase, okay, making them resistant to beta-lactam antibiotics. Okay. The problem is that ESBL positive microorganism, the incidence in countries like Jordan, where there's no such a thing as antibiotic stewardship, is a real problem. It's a very big problem in our country, okay? And that's because of the unsupervised prescription of antibiotics. So because they are extended spectrum beta-lactamase producing, so they have resistance to almost most of the beta-lactams. So the treatment of choice is carbapenem in this case. Okay? So carbapenems are beta-lactams, however, they are resistant to being broken down by the enzyme produced by the bacteria. So making this bacteria still susceptible to carbapenems despite the production of beta-lactamase. Okay. What is KPC? It's Klebsiella, pneumonia carbapenemase producing bacteria. Again, this is increasing in Jordan in tertiary hospitals due to the excessive use of antibiotics. So for this, either you need combined coverage of antibiotics or you hit with a very strong and broad spectrum antibiotic like colistin, which is as well a very toxic antibiotic to use. Monobactams, a quick example is Astrina. They only cover for gram-negative anaerobes like Pseudomonas, so they don't cover for gram-positive anaerobes, making their use is a bit limited. However, they come in handy in patients with penicillin allergy because they don't have cross-reactivity with penicillin. However, they have cross-reactivity to ceftazidime. Cross-reactivity? خدته بالمايكرو صح؟ relatively new and expensive. لا أكثر. لا في سكي. It has been there. بس إحنا عندنا very limited use. ما أتوقع إنه عندنا allergic for they're very expensive still. Okay. Okay. Glycopeptides like vancomycin. It's a bactericidal antibiotic. It can be given sometimes as PO, so نفس الفيروس تاعت IV تنعطى PO in specific indication, which is to treat Clostridium difficile. Okay, it has a very poor absorption through the gut or the GI. Vancomycin is known for its nephrotoxicity, so always before you start vancomycin, you have to have a baseline kidney function test of the patient. You have to monitor the kidney function test every now and then, and you have sometimes to do what we call vancomycin levels to check for their blood levels. Sometimes if they do exceed the level, you have to stop them or decrease the dose. They don't, they're known for, as I said, for their nephrotoxicity and ototoxicity. They cause a very common rash, which we call red man syndrome. It's not an allergic reaction. So patients who develop red man syndrome after the initiation of vancomycin, they're not allergic to vancomycin. So they can have it or receive it in the future. But what happens is what we call histamine-related phenomena. Rapid infusion of vancomycin can cause sudden degranulation of mast cells and the rash that you can see in this photo. How to, in the future, avoid this? By giving pre-medication. So before starting the vancomycin, you can pre-treat with antihistamine, sometimes corticosteroids, and to slower the infusion of vancomycin. So give it over a more prolonged period of time. Bacitracin is a bactericidal antibiotic that can be only used for topical infections like skin or eye infections. Okay, daptomycin is a cell membrane synthesis inhibitor. Okay, it causes disruption of the cytoplasmic membrane of specifically gram-positive bacteria, makes it very strong against methicillin resistance Staphylococcus aureus and vancomycin resistance enterococci. Okay, it's given only through the IV route. It can be given above the age of 2 years. However, you need to monitor sometimes for significant side effects like rhabdomyolysis. Other forms of antibiotic protein synthesis inhibitors, so in general they are bacteriostatic. An example to that, as we said, okay. So usually protein synthesis inhibitors are, as I said, bacteriostatic. However, there's an exception like quinolones can be either bacteriostatic or bactericidal according to their blood concentration. An example to that is sulfonamide. The most common one used is Bactrim. They inhibit folate and specific folate synthesis. As I said, they are bacteriostatic. However, they have significant side effects like significant bone marrow suppression, G6PD, hemolytic crisis, skin rash, sometimes false elevated creatinine levels, transaminitis, and cholestasis. Sulfonamides or Bactrim, they do cover for methicillin resistance Staphylococcus aureus, making them a good option for skin infections. They also cover for most of UTIs. Okay, protein synthesis process, an example to that, the function of DNA gyrase inhibition, which plays a role in transcription and translation. An example to that are the fluoroquinolones. So ciprofloxacin, levofloxacin, and moxifloxacin are common antibiotics above the age of 18. So you can't use any of those antibiotics before the age of 18 due to their effect on the growth plates and cartilage. So they are bactericidal, okay, and we use them when we want to target pseudomonal infections in general, okay, and they also they have a good coverage against atypical bacteria like mycoplasma or chlamydia pneumoniae. صوت مين بده نكمل اليوم؟ مش فاهمة. طب المحاضرات الجاية ايش اللي عندكم؟ أنا ايش عندي لكم محاضرات؟ لا في immune deficiency. ممكن نكملهم قبل محاضرة الاميون ديفشنسي. عندكم نفس اليوم ايش محاضرات؟ فاهمة. قصدي بنفس اليوم الخميس عندكم محاضرات صباحية؟ كم محاضرة؟ نفس المشكلة حصلت. فاهمة. تحبوا نأجل نص المحاضرة next week؟ مين مين لا؟ مين نأجل؟ أجل. طيب. احفظوا وصلنا